Okay, everyone. So we'll move to the CML session. So today we are invited speaker from Australia, Dr. David Young. Maybe you can show his. Maybe you can introduce him briefly. So Dr. Young, originally from Australia, his major field is for the CML. He did a lot of work in the clinical study for CML, also developed several guidelines. Today, he will share us the topic. He will share us optimize use TKI in the current management of CML. Dr. Yang is still on the line. So, Dr. Yang, please give your presentation.
Thank you very much. I hope you can hear me well, and I hope you can see my slides. Thank you once again to the organizers for asking me to give this talk to the Asia Pacific Leukemia Consortium. Apologies, I can't join you in the very lovely city of Chiang Mai. So let's get this started. So my disclosures. So I've been tasked to give a very overview of how we manage CML in 2024, setting the priorities, looking at how we prognosticate a newly diagnosed patients and discussing some of the treatment options. And at the end, we'll talk about what may be interesting just around the corner. Unfortunately, I do not have time to address the topic of treatment-free remission. So, but hopefully if there were any questions, we can address that at the Q&A session at the end. So the first thing to say about CML in 2024, as it was in 2000, as it was in 1998, etc., is that we must still avoid disease transformation. So this is from a slide that Naranisha Muganathan and Tim Hughes from Adelaide put up for the ASH Education talk 12 months ago now. And here you can see that the transformation rate for imatinib is roughly double that of second generation TKIs, the more potent imatinib, dasatinib, and bosutinib. And the imatinib transformation rate ranges from 4 to 8%, and the second gen 2 to 4%. How do we predict disease progression? So most of us now use the ELTS score. On the right, you can see that the separation of the curves between low, intermediate, and high is much better in the TKI era compared to the SOCAL score. And the variables that go into the formulas are the same, but the formula is slightly different, and it's easily calculable with online calculators. The other thing, of course, to say is that cytogenetics still has prognostic significance. This is a slide from the MD Anderson data. More additional cytogenetic abnormalities equals worse prognosis or higher failure-free survival, and in particular, lesions such as chromosome 3q26 abnormalities are particularly nasty in their hands. So more recently, there is increasingly data associated with additional genomic abnormalities, and these are defined as mutations in genes that are not BCR-ABL, usually present in the myeloid clone at diagnosis. This slide comes from this German CML5 or the TIGER study, and you'll see that a number of mutations up here, they are the ones that we would normally associate with myeloid malignancies such as ASXL1, BPL1, DMNT3A, TET2, RUNX1, etc., of which ASXL1 mutations are the most prevalent if a mutation is detected. This is work from Naranisha and Muganathan from our laboratory in Adelaide, working with Sue Branford. She found very similar results, i.e., if patients have an additional genomic abnormalities, in purple there, they have inferior failure-free survival compared to patients with no additional genomic abnormalities. And very interestingly, you can see that there is an increased rate of acquisition of kinase domain mutations for patients with additional genomic abnormalities at diagnosis. This slide is to illustrate that regardless of whether you use imatinib on the left versus a second generation TKI on the right, you'll see that there is that separation in failure-free survival if you stratify your patients according to their status of whether they have an additional genomic abnormality or not. Those patients with an ASXL1 mutation seems to have the inferior survival even compared to the other variants, and that's the purple compared to the red. Again, regardless of whether you use frontline TKI versus a second-gen TKI. And I should say that the Germans, as well as the Koreans and the Canadians and a few other groups have also found very similar findings. The other very powerful prognostic indicator for failure-free survival and to predict for achievement of molecular response is molecular targets that are time dependent. So for instance, you'll see here patients, if they have very sensitive disease, they are supposed to achieve all their time dependent molecular targets, starting with the first milestone, which is early molecular response or BCR-ABL less than 10% at 3 months. And this is a consensus position, whether we're looking at the US-based NCCN guidelines versus the European-based ELN guidelines. And again, at 6 months, patients are supposed to move towards a deeper response, so less than or equal to 1%, and then achieving MMR at 12 months. Obviously, patients that have deeper response at each of these time points, of course, are doing even better, but these are the minimum criteria for classification of optimal disease. And then, of course, conversely, if you have greater than 10% at 3 months in particular, or 6 months, patients are at really high risk of disease transformation, high rates of kinase domain mutation acquisition, and high rates of failure. So if the early goal is prognostic, then we can have a look at the early molecular response rate, or the flip side, which is failure to achieve early molecular response, and see how the drugs stack up. And this is a summary slide that I've used for a few years now, looking at all the registration trials, which compare imatinib against the second-gen TKIs as well as the third-gen TKI ponatinib. And you'll see here across the board, about a third of patients starting imatinib 400 milligrams will have BCR-ABL greater than 10% at 3 months, failing to achieve the early molecular response. The rate for second-gen TKIs are listed here, and you can see that it's between 10 to 15%, so fairly uniform. And then for ponatinib, in the EPIC study that was cut short because of an early arterial occlusive event signal, the 95% of patients actually achieved their early molecular response. And we'll talk about this in a sec, but we have just over 5 months ago now, publication of the Ask for First data that compare asciminib against standard of care therapy. And in that trial, the 40% of patients on imatinib failed to achieve the early molecular response compared to only 10% in the asciminib arm. Again, suggesting that asciminib is quite potent for frontline therapy. So on the flip side of disease progression risk is side effects or adverse events. And one of the ones that we most comes to the forefront of mind is cardiovascular events or arterial occlusive disease. This is a long-term follow-up of the ENSND data comparing nilotinib at 300 milligrams twice a day, 400 milligrams twice a day versus imatinib 400 milligrams once a day down the bottom there. And you'll see that there is a dose and duration of treatment dependent correlation between nilotinib and cardiovascular events. And you'll see that the rates don't actually change very much as patient has additional years of treatment. It's about 3 to 5% per year. And for the 400 milligrams twice a day, it is a bit lower with the 300 milligrams twice a day. And the comparison to imatinib is quite significant. This is old data now, but an American group did a meta-analysis looking at the effect of other TKIs and their association with vascular occlusive events. The odds ratio 1 is imatinib, and what they concluded was that with second and third generation TKIs, there seems to be an increase in vascular occlusion risk across the board. So as a result, all of us that look after CML patients are aware that if we are to use a second generation TKI, patients will respond faster, but we will need to address cardiovascular risk very stringently if we are going to see that long-term benefit. As I said before, I won't have time to address treatment-free remission, but it does deserve 1 or 2 slides worth of mention. So treatment-free remission, as many of you know, is a stage where patients have achieved a deep and durable, stable molecular response, BCR-ABL either defined as less than 0.01% or MR4, or more commonly in Australia is defined as 0.0032% or MR4.5, and patients who have achieved a durable and stable MR4.5 are allowed to have an attempt at treatment cessation that's medically supervised. And over the last decade and a half, we have found that about 50% of patients will never need their TKI again, versus the other 50% needing to restart treatment. And a number of groups across the world have tried to look at trying to prognosticate and understand the factors that lead to TFR success. And this is aside from Narani Shanmuganathan's work, working with Sue Branford again. And what she saw was that patients with what we call a BCR-ABL halving time that is rapid tend to have great an improvement in the success rate of TFR. The BCR-ABL halving time is calculated when the patient initially start therapy, and it is defined as the slope or the number of days that the BCR-ABL reduced by 50%. So conversely, what we did find was that when patients have their BCR-ABL reduced very, very slowly in the initial part of their therapy, then the TFR success rate is greatly reduced. So this again speaks to the early period of CML treatment being critical, not only for achievement of deep molecular response, but even after patients have achieved their response, it is very predictive of the underlying disease biology associated with residual clones. And obviously, we want patients to get to TFR because ultimately, when you actually stop, when you're in a position to stop TKI, then it is the ultimate management to avoid any long-term side effects and to address any short-term side effects. I should also come back and say that this is the Euroski data, and many groups have shown this. One of the critical determinants of TFR success is the duration of MR4 or deep molecular response. And coming back to what we were originally talking about, how to actually choose a therapy, obviously the faster and the deeper a patient has in terms of their disease response, the longer the duration of MR4, and therefore the greater the success of TFR. So once a patient has started a frontline therapy, what actually happens to them? There is now very good trial data as well, real-world data, to suggest that first-line therapy in many patients is an event that would eventually lead to switching to a second-line therapy or third-line therapy. This is the Italian campus CML study. This is real-world data in their database with close to 1,200 patients. You'll see in the blue line there, anybody that started imatinib in their cohort, there's a 40% chance of needing to switch to another TKI by 3 years after diagnosis. For patients starting dasatinib or nilotinib, in the red line there, that cumulative incidence is closer to 20%. On the right there, you'll see that the reasons for switching, half of them are what we would traditionally call resistance. The other half is toxicity or intolerance. You'll see here in all the patients, 40% who stopped, you'll see resistance there add up to about 15%, and then toxicity, the resistance there add up to 10%, and then resistance add up to toxicity add up to about 30%. This is another cohort from the Imperial Hospital in Hammersmith. This is all the patients that they've started on second generation TKI in the frontline setting. There's 100 patients here. You'll see that the proportion of patients needing to switch is very similar to the Italian campus study. 25% for intolerance, 15% for resistance, and only 40% didn't switch. So the priorities for CML treatment and management in 2024 and beyond, as I said, all of us wants to minimize disease progression and blast crisis because of the very difficult to salvage nature of blast crisis. We want to limit and manage toxicities because patients are living longer, and we don't want to settle them up with a stroke or heart attack that would limit their full potential to carry on with their lives. And we also recognize that there are many low-grade toxicities that decrease the quality of life of patients. How do we address this? So if we can actually maximize deep molecular response, then that would lead to superior event-free survival, and it would also act as a platform for TFR. And I've also demonstrated, I think, the case for better treatments, because 30%, 40% of patients discontinue their frontline therapy. And because of that, we need better frontline therapies, and we need better second line and third line options for those patients who've already started. This is the Australian perspective of how we think about changing drugs. I think it is pretty similar all across the world, and also in the Asia Pacific region, how ponatinib and asciminib are considered third line therapies. And that is the same with Australia. So if a patient start off with imatinib, traditionally we would pick a second gen TKI for failure or intolerance. For patients going from starting a second gen TKI, there's not very much evidence to suggest that switching between second gen TKIs will be helpful. Nonetheless, sometimes we are forced to do that because of regulatory limitations before going to either ponatinib or asciminib. Mutation analysis, BCR-ABL kinase domain mutations, whether done by NGS or by Sanger, is helpful because there are certain mutations that wouldn't go with some of the drugs. And then patients going to the third line setting, there is evidence that if one drug doesn't agree with them, either because of toxicity or resistance, at least in Australia, they can switch between the two. T315I is a bit different because, as many of you know, it confers resistance against isatinib and nilotinib as well as imatinib. So if we detect this mutation, patients do go straight to either ponatinib or asciminib. So in the next few slides now, I just want to go through the evidence for these two frontline, for these two third-line options. So a couple of slides on the OPTIC study, the most recent study that describes how we use ponatinib. Patients with in the third-line setting in this study were randomized between ponatinib 45 milligrams versus 30 versus 15, because we know that ponatinib is a very good drug, it's a very potent BCR-ABL inhibitor, but there is, at least in the PACE study, an association with cardiovascular events and peripheral arterial occlusive events. The question of the OPTIC study is whether we can use a lower dose and achieve a good rate of molecular response. And this summary of response is here. So patients who started off at 45 milligrams once a day, as soon as they achieve BCR-ABL of less than 1%, they dose reduce to 15 milligrams, the lowest dose that we think is necessary to maintain that response. There's a very high achievement of that molecular endpoint of BCR-ABL of less than 1%. There is an acceptable rate of arterial occlusive events. However, you'll see that both the response rate and the toxicity, there is a dose-response relationship, such that if you were to start a patient on a lower dose of 15 milligrams, you'll have they'll be less likely to achieve that molecular response, and the rate of arterial occlusive event is also correspondingly lower. So the summary of, in my mind, how to use ponatinib is assess the risk of your patient in terms of disease progression, how resistant the disease is versus the risk of cardiovascular event, and pick a dose. Start that dose, and as soon as patients have achieved some kind of response, come down to a dose that would maintain that response. And that's why we thought to be 15 milligrams. The other option is asciminib. It is a myristoyl site inhibitor. Many of you would have had the opportunity to use it by now. On the right is a BCR-ABL protein cartoon. You'll see that in ATP site, nilotinib, imatinib, and dasatinib binds, and away from that, in red there is the myristoyl site where asciminib binds. It was called ABL001 previously. The evidence for its use in the third-line setting comes from the ASSEMBLE study, where patients were randomized to asciminib versus bosutinib. And the summary slide is here. There was significant superiority for patients being assigned asciminib. This is the MMR rate, both at week 24 early, as well as the most recent update at week 156. You'll see that there's a significant difference in MMR achievement between asciminib versus bosutinib arms. One of the reasons is this. This is the AE frequencies. For bosutinib patients in blue, you'll see a number of patients have significant GI side effects compared to patients in green. So those who are assigned asciminib, you'll see diarrhea, nausea, vomiting, as well as derangement in LFTs, and a number of patients assigned bosutinib actually discontinued, and they probably didn't take drug for long enough to actually achieve a molecular response. There was a recent update at the John Goldman meeting in Prague, presented by Jorge Cortez. This is data from the original phase 1 study, where asciminib at the higher dose of 200 milligrams twice a day was used for T315I mutated patients. You'll see that until with quite long-term follow-up, 432 weeks, this is a very clinically significant MMR achievement rate of patients both ponatinib naive as well as those failing ponatinib. This really, again, confirmed the basis for asciminib use in T315I mutated disease. Being so promising, then, in the third line setting, obviously we want to try to see the activity of this drug in the frontline setting. And as I previously mentioned, the ASK4FIRST study is where this question was examined and was presented back in June at both ASCO and at EHA, and the paper has been published in the New England Journal in May. This was a randomized study where the investigator was asked to predetermine whether the patient would enter the study using a second-gen TKI as the standard of care or imatinib as the standard of care, and based on that, they were randomized to asciminib in their different stratums. One of the interesting things that I took from the baseline characteristics is that hematologists around the world are actually thinking about cardiovascular risk and age, and you'll see that those patients being randomized or being predetermined to be in the second generation TKI stratum is on average 10 years younger than patients that their docs picked imatinib for. And down here, the Framingham's cardiovascular risk score, you'll see here that second generation TKIs are reserved for patients who are mainly low risk compared to imatinib used for patients with high risk. So I think this actually is gratifying because it tells me that hematologists around the world are pretty uniform in their practice. I'll go straight to this slide, which summarizes the discontinuation rates. You'll see that asciminib discontinuation rate is 14% compared to imatinib, around 36%. So the imatinib arm is very close to what we saw in the real life settings, of which the majority were either resistance or intolerance. So resistance here is 20% and intolerance is 10%. Again, the rate is very significant compared to the asciminib rate. The second generation TKI discontinuation rate is intermediate, about 20%. So again, this bears out what the Italian campus study tells us. Again, it's a mixture of resistance, 10%, and toxicity, 10%. The endpoint of this study was MMR at week 48, and there was a significant difference between the asciminib treated patients and those patients receiving the standard of care. And that difference is apparent across all the other molecular response categories, such as EMR, MR4, and MR4.5. So there's a difference in MMR achievement as well as deep molecular response achievement and early molecular response achievement. If we look more closely at the data, especially with regards to the primary endpoint, the difference in the primary in the MMR achievements is driven by the difference between imatinib treated patients, 40%, versus asciminib treated patients, 70%. Because if we actually look at the second generation TKI, the difference is actually much smaller. In terms of toxicity, the hematological toxicity is pretty similar across all three drugs, and we would expect that for a BCR-ABL inhibitor. The non-hematological toxicities, the summary that I get is that most of them were grade 1-2 events. There were more events in the standard of care arms, i.e. the imatinib and the second generation TKIs compared to asciminib. And again, that makes sense after looking at the discontinuation data. too early to call arterial occlusive events yet. The early data is encouraging. I think, as you would expect, imatinib, very low rates, 0 reported. But remembering that there was significant discontinuation, so I don't know how to actually report, how to interpret that. This asciminib is here to the left, seems to be no worse than second generation TKIs to the right, if not a little bit low. In Australia, we ran our own frontline study. It's a phase 2 study, and that enrolled 100 patients. This has also now been published in Blood. We use asciminib in the frontline setting, initially 40 milligrams BID, then changing it to 80 milligrams once a day. And we also saw really high cumulative incidence of major molecular response and deep molecular responses. So the MR4.5 rate is particularly encouraging at about 50% after 2 years. We had 1 patient transform, but we did see a number of secondary resistant events, and we had 1 lymphoid blast crisis, as I said, and there were 7 or 8 patients who lost their previously achieved molecular responses. We found BCR-AML mutations in all of these patients. You can see that the 337 and the 244 seems to be the Achilles heel of resistant mutations with asciminib. We also saw a 315. The majority of these patients actually was then treated on dasatinib, and we're awaiting further data. The patient with the lymphoid blast crisis had induction chemotherapy and then was transplanted. What's the alternative to asciminib if we were to consider frontline drugs for the future? Obviously, we still have imatinib and nilotinib and dasatinib. I think one way to use dasatinib better is to think about how to avoid pleural effusions, in particular as a side effect. We ran this study through the ALG in Australia and New Zealand, where we started patients off with 100 milligrams of dasatinib, and then we did trop levels, and we picked a dose that led to the patient achieving an effective plasma concentration. And we found that most of the time patients could actually dose reduce to 50 milligrams once a day and still have a safe and effective dose of dasatinib in the plasma. In the end, we saw a really high level of MMR achievement, about 80%. MR 4.5, this is close to 3 years there, up to 70%. But we still saw our fair share of pleural effusion, especially in patients greater than 75 years of age, 36% cumulative incidence, even though the majority of these patients were dose reduced to 50 milligrams once a day. There are other studies around the globe looking at this approach. The MD Anderson has really encouraging data using low-dose dasatinib. There's another Indian study that also reported similar outcomes, and then our own data, very similar MMR rates between us and the MD Anderson. So what's next for the ALG from our perspective? I showed you the prognostic significance of additional cytogenetic abnormalities as well as additional genomic abnormalities. So what we've just activated just last week is the CML14 study, where patients will be treated on asciminib and for a month whilst we actually do the next-gen sequencing analysis. And after the end of that month, if patients have AGAs, then we would use combination therapy of asciminib and dasatinib until they achieve MR4, and then we'll de-escalate. Patients who don't have any additional abnormalities then will be treated on asciminib monotherapy. In terms of asciminib resistance, I've illustrated to you the kinase domain mutations of importance. There's also increasing data suggesting that if you take out the SH3 domain of ABL, you will have resistance to asciminib. And one of the most common clinical situations where that occurs is in the rare E13A3 or E14A2, E13A3 or E14A3 transcript type. We see it about 1% of the time, or even less than that, but there is increasing data from 2 laboratories now to suggest that that is resistance. Finally, there's also data suggesting that compound mutations where cases are resistant even to ponatinib, there seems to be some useful activity if you combine ponatinib and asciminib to try to synergistically inhibit BCR-ABL at both sites. And this is data from Chris Eade in Brian Drucker's lab. So the conclusion for CML therapy in 2024, I think TKI selection upfront continues to rely on a balance between an individual's disease progression risk versus their comorbidities. We know that of the drugs that we have available, whatever we pick, we need to be vigilant for resistance and intolerance because a significant proportion of patients will need to switch drugs. Asciminib, which is a myristoyl pocket inhibitor, seems to be very promising in the frontline setting. And I'm just talking on the scientific merits alone because I know that the financial incentives are probably very difficult to navigate at the moment. And future algorithms, I think, will increasingly incorporate genomic data, and we're trying to demonstrate that prospectively in a clinical trial. So thank you very much for your attention. I will leave it there.
Okay, thank you, David. So very wonderful talk. So really many new information bring to us, especially for new generation of TKI, or show us very good tolerability and safety profile. So really maybe change our clinical decision in the treatment of CML in the future. So we'll ask Dr. Goh to moderate the discussion.
Maybe we can invite the panelists to come aboard, Adisak, Tang Hin, and Jerome. Hi, David. Good to see you.
Thanks, Prof. Goh.
Okay.
Good morning to everybody.
Yeah. Hope to catch up with you in person. So I think this is a good time because we have not had a CML session for the longest time. I must confess CML was my first love, but I was not faithful. So I've been running away to other disease conditions, but now it's good to come back. Unlike some like David who has stayed faithful to CML.
Good to have you back.
Anyway, I'll be asking some questions as a start for poll, and then I know there are a lot of CML experts in the audience. We don't have the chance to invite everybody up on board, so don't be shocked if I ask you to answer some of the questions. Can we have the first polling question? And these 3 questions will serve as the basis for some of the important points that David has brought up. Okay, question on Blink, and can you scan your Menti to vote? So what we do in a patient who has achieved BCR-ABL between 0.1 and 1 in first-line TKI after 18 months. So switch therapy, increase the dose of therapy, do a KT mutation, and then switch based on mutation, or maintain sim therapy. Can you all please vote? Okay, very interesting. So majority wants to switch based on KD mutation and switch based on mutation results. And one third will maintain same therapy. So I guess this is, if you follow the ELN guidelines and you listen to what David shared, this will constitute a warning under the latest ELN guidelines for 18 months and 12 months. And it will depend on what your aim is. If your aim is survival, then they'll say it's optimal. Whether you believe 1% is optimal for survival. Some of us, are perfectionists. We know that we have patients around between MMR and MR3, MR4, MR2 that actually have progress. But it could be optimal, but it's very, very small percentage. So whether you're a perfectionist or not, so that's number one. And of course, it's not optimal if you want TFR. So I guess that will be where the question is asking. Maybe we go around the table. Adisa, what would you think?
I think for the treatment is you have to balance efficacy and toxicity and what you aim for. As Professor Go already said, if you want TFR, probably you need more deeper response. You probably want to go to the deeper response. So you switch the therapy should be the good way you go. And and you have to balance. If you want to switch the therapy, you have to balance which generations do you want to go with the TKI, because different TKI there may different toxicity. But if you aim for only survival, maybe only less than 1% should be a good point that you would balance. I think it's individualized to any patient what you aim for. So you aim for efficacy, you talk to the patient, but you need to be careful if you want to change the therapy to balance the toxicity with the TKI. That is my point, I think. Yep.
Again?
Yeah, so I think I agree, like pretty similar. So it's depending on the intent. So let's say in a young patient that we are aiming for DFR, I think we'll be more keen to switch after 18 months of not achieving MMR, because this will be considered as failure if the intent is for treatment free remission. But other than that, of course, what I will be doing is definitely checking the compliance. At the same time, I think even if I'm not switching, I will still do KD mutation to make sure that that's not the reason MMI has not been achieved. Yeah.
Adisa? Jom.
Just
Sorry,
to
sorry.
add on to my other colleagues, sometimes I do see the kinetics of response. If patients are continuing to respond rather than plateau off, I might continue the same therapy. Also, there is also an option to increase the dose, which I occasionally do, because we know for imatinib, certainly a slightly higher dose may confer additional efficacy. So. In addition to what the points my colleagues have made.
We'll be dealing with David's point. Those longer terms of all doses, or even switching, comes with a price. And as a lot of my patients with long term, I would actually kind of regret, because you have long term toxicities with either cardiovascular risk. If you switch to second generation, if you imagine it, it's either the low grade toxicities or even renal failures. I've a lot of patients that are 10, 20 years on that, and then their a lot of them are seeing nephrologists now. And I was wondering whether I should have switched on earlier and all that. Maybe we can discuss that later. Lynette, can we ask whether you believe that one between MR2 and MR3 is safe? You believe NCCN that is really safe? And would you, can we see, what do you think? Can we have a
Hello? Oh, hi, Prof. Go. So I assume you're talking about first line treatment.
Yes.
So obviously, I think it's already been touched on. If it's a younger patient, obviously we want to achieve MMR because that is associated with better outcomes in the longer term rather than just under 1% response. And obviously, deeper response is very important if we're going to aim towards TFR attempt. In the later line setting, then 1% obviously and lower is associated with better progression-free survival. So it's different. So in first line setting, I'll aim for a deeper response.
Okay, David, anything to add to that? Would you be comfortable with your patient around MR2 in the younger patient and long term not going for TFR?
Yeah, I think as everybody else has said, if it is someone where they are less likely to want to achieve TFR, and older patients where I prioritize cardiovascular safety, I would likely leave them alone. Although most patients, especially if they're on imatinib, if they want TFR, then I will try to switch them. Now, conversely, if they are already on a second-gen TKI, then I think they would have to go to either. We try not to use ponatinib for this indication. As you know, there is Novartis is running a study called I think it's called Ask for More. I don't think it actually has a readout yet, but it is actually addressing this particular question. Patients that have achieved a response but not a deep molecular response, whether switching to asciminib will do anything, and if so, what the toxicity profile is and what the success rate is. So we're waiting for that readout. But I agree with everybody. For survival, I think that's fine. But for deep molecular response in TFR, then I think you have to do something.
Proctor, so I was just going to say one additional
Sure.
thing is just to look for concomitant medicines as well, especially dasatinib and PPIs. I think it's really important to check for those because it could be affecting your responses too.
Sure. I guess it's also depending on where the patient is. I guess if it's like youngish patient on imatinib and they have got some side effects here and there, I may be tempted to switch. I guess it will depend on that. Carol, I see you're nodding. You want to give us your Hong Kong perspective? Microphone.
Thank you, Prof. Thank you, Prof. Yan. This is Carol from Hong Kong. And just back to the question, I think it's kind of in the gray zone. I mean, it is not clearly failure signal yet. I mean, not reaching MMR at 1 year. So I think personally, I would just take into many other factors into consideration. One I personally would think would be the trend of the QP cell, of the B cell ABL level. I mean, usually if it is still on downward trend, but just like usually more slower when you're reaching 0.1 level, then I would usually just confirm the compliance, the drug compliance of the patient, and then maybe press on for a while, and then have an early recheck, maybe after 2 or 3 months. So usually, I mean, some patient actually, if you see the data from various drug trial, in fact, more than half of the CML patient will not be able to reach MMR anyway at 1 year. So I think for that matter, of course, in the long run, I would still wish to have that at least MMR as a target. But I think I would not be too anxious if it is on a downward trend already.
Yeah, I think Carol has a good point. Depends on the trend and where you're hovering. So usually some of these patients, they bounce around, and where they bounce around. If they bounce around MR2, then I'll be a bit more wary and I'll probably be more keen to switch. If they bump around MR3, then I suppose I'll be a bit safer. So all these are like nuanced kind of things to how we treat. Okay, maybe we move on to the next question. Okay, so what is your top priority in selecting first-line treatment for newly diagnosed patients? MMR, cost effectiveness, minimizing toxicity, as we heard a lot of toxicities, or attaining TFR. Can we please vote? Okay, I'm honestly a bit shocked at the answer. So during the previous session, we've been talking. So David, you were not here. We were talking about cost of drugs and Asia Pacific setting and all this sort of thing. But I'm a little bit shocked. Maybe we can discuss that. Maybe I ask my co-chair Jian Xiang to sort of opine what your aims are and what do you think of the result.
Yeah, but according to the recent achievement, I say Samuel, definitely will pursue TFR, pursue early response and deeper response. But however, when back to the clinical practice, many manufacturers should be taking into the consideration, including the price, reimbursement. So why we choose the cost effective? So really in the theory and clinical practice, a little bit has a gap. So it's my
I guess it
opinion.
depends on your system. If it's a
Right,
fully reimbursed system,
definitely.
then you don't worry. But if you have to pay for it, then you have to talk to the patient. But how do you weigh against your life and cost, and so forth? But it's interesting to hear the perspective.
Absolutely.
Maybe we ask Prof. Ho from Taiwan. Xingan, yours is the reimbursed system. So what will be your priority?
I think in Taiwan, all these three test inhibitor are reimbursement as a frontline therapy. So I think for the majority of data, consider achievement of a major molecular response and also a high probability of a treatment-free remission are the treatment goal. Of course, for some minority of patients with comorbidity and potential higher risk of adverse effect, sometimes you will choose a different strategy.
Can I ask Park Lin from Singapore, the other university, what your thoughts are?
Yeah. So in Singapore, the first and second generation TKI are all reimbursed for first line setting. So I actually chose C, which is minimizing side effects. But in reality, it will depend on the patient profile. So in a more elderly patient, then the risk of having cardiovascular side effects will be higher. Whereas in younger patients, then we would prioritize TFR. So yeah, it depends on the patient profile.
Yeah, so I guess everything has a price. You start if you want TFR, you go for second gen, but long term, cardiovascular events and so forth. Whereas, but everything is changing. As for first, asciminib has been approved, and although we can share and discuss the long term toxicities and cardiovascular events for asciminib in the next question. So those of you who have not been following the news, asciminib in first line setting has just been approved 2 or 3 days ago, FDA. So congratulations, Novartis. Maybe next year you all can have a bigger booth. So, David, what do you think? Normally for us, for me, I would discuss with the patient what the objectives are, and then see what they want, and then counsel them on all the side effects and for each of all the second gen if they want, and perspective. Do you still use imatinib, or do you guys hardly use imatinib?
No, we still use imatinib, especially for a patient where toxicity is going to be a concern, such as a more elderly patient. But I think going back to your original comments, I am also quite surprised by the result because I don't know what it's like around the Asia Pacific region, but in Australia, we now have generic dasatinib, and I think we are about to, if we haven't had, I think we're very close to, if not already, we also have nilotinib on generics. So I think the costs will be very similar to us in Australia, whether it's imatinib, nilotinib, or dasatinib. But I also think that the question was a little bit unfair because in my mind, trying to minimize toxicity and maximizing MMR, I think, is very similar questions. They're two sides of the coin because in almost all the studies, one of the major impediment to patients achieving molecular response is toxicity leading to discontinuation. So I think, as everybody has said, those are two things that must be considered together.
Okay, good. Let's move on to the next question. Can you advance, is it? Okay, so would you consider switching from first gen or second gen TKIs to a STEM inhibitor, misoprostol, we are talking about asciminib, for patients with significant adverse events greater than grade 2, with persistent low-grade events, grade 1 to 2 for more than 6 months, or with treatment failure? Can you please vote? Okay, good. I think this is probably more in line with what I expect, but maybe some of us may have a contrarian view. So basically, you've heard David did mention correctly that that the S for first data is a bit too immature for long-term effects for asciminib. But however, I think we have published and we presented and are publishing the long-term follow-up data for the phase 1 asciminib data. So the asciminib phase 1 is one of the longest phase 1s we have run. It's like 8 to 10 years, a patient up 10 years, still on follow-up, and we have like well over 100 plus patients on it. And actually, to be honest, the long-term data is very, very, very good. Okay, there's really no long-term cardiovascular events and no new additional events beyond the third, fourth year, and all the acute GI and all that actually all goes away. So asciminib is really quite well tolerated, very well tolerated. Novartis, okay, so we mentioned that mitigating adverse events is important. One of the teams from EHA and all that is actually that we actually can dose reduce. David has presented the data to attempt to reduce dasatinib and ponatinib and also and so forth. So you don't have to like in attempt to mitigate all these side effects long term. So so maybe we can go around. Adisa, maybe you want to comment on the polling results and what would you do?
Yeah, I think I'm gonna go for both. If you have treatment failure, you change the treatment, and if you have intolerance, yeah, you have serious toxicity, I think you switch anyway, because we need more detail for the question, like you say, because different TKIs they share hematology toxicity, but for other serious event is made different. You know, when you on dasatinib, you have recurrent pleural effusion, you can and it's serious and it's quite high grade and it's recurrent, you're gonna change the treatment anyway. And another thing, because if you failure, you see that failure, you don't have a good survival, you need to change the treatment anyway. I think it depends on the patient, and I think I can, if there is an answer, all of above, I can answer it. Yeah, for that question. Yep.
I guess the question should be phrased in like different grades. You know, the like grade 1, 2. If you have grade 1, 2, then it should be first. Then go down. All of us will switch in favor. So Tang Hin, I think you and I have discussed. A lot of us are quite have patients with low grade adverse events, and we're wondering whether to switch, especially if they are like in MMR or so forth. But you know, they will actually will have some quality of life issues and so forth, and given the data with asciminib, you want to give your opinion on this?
Thanks, Marco. So, I mean, yes, definitely. So, like what Adisa said, so, I mean, all the options are like kind of potential option to switch. So, definitely with treatment failure, like what majority have answered, but patients who, especially on like second generation TKI with persistent AEs, then, I mean, that might actually affect compliance and eventual loss of MMR. So I would consider switching if they are either significant, like more than grade 2 AEs, or persistent low, like grade 1 to AE that might kind of impact patient quality of life and hence adherence. I think these are the patients that I will consider switching.
Adisa. Jerome. I keep seeing the picture, then I always go the wrong one.
Yeah,
it's been a long meeting.
Just to add on, I think these days patients are a little bit more educated, and sometimes patients' preference will be considered, because taking an oral treatment is based on patients' own compliance and willingness to comply with the treatment. So I think it's important to minimize the adverse events so that patient will not have treatment interruption. Continuous treatment is important. And these days, if access is not a problem, I think patients also frequently inquire regarding alternative treatments. And I think switching treatment based on tolerability and adverse events by patients is a valid reason to change. Yeah.
Lynette, can we hear your perspective on this? About especially, I think the treatment failure, and none of us will disagree, but the low grade long term toxicities and all that. Whether you do you switch, or do you, in the past we are a little bit diffident to switch. We will just persist on. But are you more encouraged to switch now that we have a asciminib available?
I do. Can you hear me?
Yep.
So I think part of it is also related to regulatory approvals, because in Australia we can only use asciminib as third line treatment. So if you've started with a second gen TKI as first line treatment, you might have to try nilotinib. So, for example, you started dasatinib, you might need to try nilotinib. We call it also intolerance before you can move on to asciminib. I do think, however, as David has presented and other people in the room have tried, asciminib is very tolerable and it's got minimal side effects. I've got patients with pacemakers who are on it. So I would also swap for intolerance, because as has been mentioned as well, intolerance and tolerability of the drug also leads to efficacy. So they're kind of interrelated. But I think it's also related to what you can access and when, in which line.
Yeah, so Novartis is doing a second line asciminib trial. Hopefully you'll get started. And then as for more, Carol, you want to opine on this?
Thank you, Prof. Goff. And I agree with Linda that and everybody in the room that in my experience, asciminib is really a very well tolerated drug. I mean, sometimes for imatinib, I mean, it is usually fairly tolerated, but some patients do complain of some ankle edema, some frequent bowel opening. I mean, or like puffy eyes in the morning. I mean, it is not killing them, but it is very bothering for them. So for these patients in Hong Kong, the third line indication of asciminib is just recently approved. And but if the patient can afford it, actually I did try to switch to asciminib from either a first generation or second generation TKI due to side effect, maybe like grade 2 to 3. And I think most of them they're very happy. I mean, some just one is dasatinib, one previously was on imatinib, have some renal impairment from the imatinib, ankle edema, etc. And then once they were switched to asciminib, everything is gone, and they were very happy, feeling normal again. So I think this is also, and they are relatively young, like before mid age. So I think it is very important for them and to maintain a very good quality of life, and to keep them so that they can work or do stuff that they really like. So I think this is really a one plus. But of course, in the like in the real world, the cost of the drug has to be balanced. I mean, some patient, if they cannot afford it, I mean, I'm sorry, but they still have to bear with it. Just
Yeah, I guess I echo your experience. I have one patient, and this is quite common. A youngish man, now about 50, he had an autologous transplant in days where there's no other treatment for CML. And then after that, imatinib for like the longest time, and his creatinine kept increasing. And then, of course, the biopsy and all that say, oh, it's probably due to the autologous transplant, but it could be drug related and so forth. So we didn't switch the imatinib, then after that, it keep getting worse. Then we had used dasatinib, and then a lot of side effects with dasatinib. And when I switched to asciminib, after he has had to go on peritoneal dialysis, actually he's very well and very much happy. He said we should have switched him earlier. So, and one of I mentioned earlier, a lot of my patients on imatinib after 20 years, a lot of them are seeing the renal physician. So if I can tell my younger self something, is actually to if in the imatinib long term with all these renal issues, if they're creeping up, I probably would switch to either an asciminib or even a second gen. David, you want to opine on this low grade side effects and all this?
Yeah, I think they are quite common, and I think in the past when we didn't actually have any other options, we had a much higher tolerance for asking patients to persist. But now I think we probably are more upfront and ready to discuss options. I Yeah, and the other thing to, I suppose, bring up is Richard Clark's Destiny study. I think if patients did achieve a stable deep molecular response, but they don't want to participate in TFR, the Destiny data suggests that you could dose modify. As you said before, Prof. Go, you don't have to, especially in patients with sensitive disease, you can consider dose reduction to see if the toxicity can be managed that way.
We have a few other topics, but I want to actually bring up one that is of interest. I think Prof. Hang also suggested that topic. And I know that in your Ascendance trial, you have the combination arm, and then also in your Ascend, it's like the title, where you have an option to actually add a second drug to it. In our phase 1, we also have published the combination with asciminib, with dasatinib, imatinib, and nilotinib. Dasa seems to be the best. And we know the German data as well for the combinations. So where do you think the combinations with asciminib is going? Would you use them for the very bad risk patients? In the patients that are not responding, will you throw in a combination? Where do you think that is now?
Yeah, I think as you said, the safety has to some extent been established between combination asciminib and ATP pocket binding TKIs by the phase 1 study as well as the German Fascinate study. In the CML13 study, as you've alluded to, we did in our protocol permit combination therapies, although fortunately or unfortunately, not many patients fail to the degree where we specified in the protocol where they would actually have exposure to combination therapy. So we only had 3 patients that that stipulated by protocol to go on combination. So I can't actually comment. But in the upcoming study, we're trying to pick the patients with a high rate of failure before they even fail. So we will hopefully have probably about 20-25% of patients being eligible for upfront combination therapy. And hopefully the tolerance will be as good as that described by the phase 1 study and by the Fascination study. And hopefully the efficacy would be great. And there is, of course, also Mike Deininger and Brian Drucker's laboratory studies to suggest that at least with ponatinib, the binding of ponatinib in the ATP binding pocket will stabilize the conformation of asciminib to potentiate any therapeutic effect from myristate pocket binding. So there is actually very good laboratory data to suggest that combination inhibition will work very well However, what we don't understand and what we don't know is to what extent is BCR-ABL independent mechanisms going to be at play at causing disease resistance.
So maybe I open this issue of combinations to the audience and to my co-chair, because Jake Sang asked the question, whether you guys have any experience using off-label combinations outside the trial, and whether would you guys use it?
Before assembly launched in our country, we don't use the combination therapy so frequently. Besides, with combination with the TKI with the interferon. But however, due to the different mechanism, the assembly and the TKI, so the combination become really practical in the therapy. But however, we're still concerned about optimized dose of both drugs. So I would like to ask David, do you have this kind of data to show optimal dose for both drug therapy? Do you have this kind of data to show us?
Yeah, so sorry, in the interest of time, I didn't show those slides, but as Proco has said, the majority of that data with very good PK measurements actually came from the phase 1 study, where there were a significant proportion of patients exposed to asciminib at the standard dose, just the 80 milligrams once a day or 40 milligrams BD, plus dasatinib or nilotinib or imatinib. And you're absolutely right. If you were to combine asciminib with an ATP pocket binding TKI, the dose that you use may be slightly different. But for instance, the dose of imatinib, if I remember correctly, I think the optimal was 460 milligrams of asciminib, I think. Don't quote me on that. I'll send more data later, but it is actually in that paper.
Asciminib is 40.
Yeah, right. So there is good data, and as we've all said, I think we're waiting for the German fascination study to come out with their data, where they've also tried those combinations in separate cohorts of 25 each.
But the sort of inkling with the fascination is that the toxicity is quite bad, and if the Germans can't tolerate, they can tolerate combinations with interferon and all sorts of high dose. If they can't tolerate, I don't think our Asian population can.
No, and you're absolutely right. So the tolerance may be an issue, but I don't understand though. The phase 1 study showed quite good tolerance.
So our phase 1, we actually have quite a few patients, and they actually tolerate quite well.
Yeah. And as you said, off-label, we've tried it with a couple of patients, and they seem to do it.
Okay, so if you want to use off-label, possible. If not, the design a study with Novartis is RIT. Okay, we are almost at the end. Any comments from my fellow panelists? Tang Hin, you want to say anything in the last minute? No. Okay, everyone's happy. Our CML people on the floor, I think everyone's happy. Carol, yes.
Thank you. Thank you, Prof. Goh. I would just like to take this chance to ask Prof. Yuen for his advice, because as you just now share your CML13 data, there are quite a number of patients who develop the mutation in the myristoyl pocket and causing some resistant problem. Is that, I'm not a lab person, but technically is that, and the current assay in my lab is mainly still the traditional kinase domain pocket mutation by Sanger. So can I ask for expert advice in how, is there any particular technical details that we have to pay attention when we design another platform for detecting the myristoyl pocket mutation? Because obviously it will be becoming more and more often used in the future. And my second question is that you also mentioned in your CML14 trial, you will take into account the AGA, the presence of AGA, to decide whether to so-called intensify or escalate their treatment. So what particular genes are you referring to when you consider the step up? And also, what would be your view in the latest WHO guideline in so-called the CML with high risk feature. Do you think it is time that we incorporate the presence of AGA into that category yet? Thank you.
Thanks, Carol. Very pertinent question. So the first question, the secondary resistance and the myristoyl pocket mutations, as well as the kinase domain mutations that I've shown you, all of them in the CML13 study were actually demonstrated using Sanger sequencing. We did, so Sue Branford is in Adelaide, so along with a couple of the others, she's, as you know, very good with molecular biology of CML. And one of the first things that she did was to make sure that our Sanger had the primers to extend the range to cover the myristoyl pocket to either side of the kinase domain. So for instance, one of the mutations, the 506 amino acid, that's not commonly seen with other ATP pocket binding TKI, so she had to make sure that it covers that region. But the 337 and 244, they're common, they're within the region that we would commonly target. As many of you know, the most recent recommendation from the EON in a paper led by Nick Cross is recommending an NGS approach. So I suspect that in Europe and in the US, many labs will increasingly shift towards the NGS, where having a limited region of BCR-ABL is not such a problem. But as I said, all the mutations that I've shown you, we could actually see on the Sanger. Your second question is using the, before I go to the second question, so the most of the patients with resistance also had AGAs in the CML13 study. I didn't actually show you that data because I think Sue Branford and Narani Shanmugamanathan will present that formally at ASH this year. But as to the design of the myeloid genes beside BCR-ABL, what we are moving forward to is the use of a consensus NGS panel to look at other myeloid diseases as well as CML. So the panel that we use in the CML14 study, the targets will be very much the targets that we look for in MDS and CMML. You saw in the German Tiger study and in our study as well, the most commonly mutated gene is ASXL1, and that's the most prognostically significant. But the other common genes are things like RUNX1, TET, BCOL1, etc. So if you have a myeloid panel that incorporates a lot of those targets, then I think that panel may very well be used with slight modification for the purpose of CML.
Sorry, David. As I said, I've not attended any of the CML meetings and updates for a long time. But our understanding for the KD mutations is that Sanger is the gold standard. If you use NGS, it's too sensitive and they're not actionable. So Carol's question is very pertinent, and I'm not aware that Nick Cross and the Americans are going to advocate NGS for the misopro mutations, and would they be actionable? If you apply the same logic for kinase domain, it's probably not. So why are we going that way?
I very much agree with you, and I think it's the same as you. But if you actually read Nick Cross's paper, it was published in Leukemia this year. He actually recommended, the way that he put it was that we would recommend NGS for mutation analysis, but if you have Sanger, that is okay too.
It's because Nick Cross thinks more business for his lab. I don't know whether it's actionable or not because it's not been shown. I don't know. Tang Hin, you're a lab person. What will you do for our lab?
So yeah, I mean that's a good point. So basically, I think recently, I didn't share earlier on. So, but in the lab, we are trying to expand, like exactly what David said. I mean, we probably also will write to Sue. But it's really just to extend it beyond to cover the 506 region to cover the sort of like a myristoyl pocket mutations. I think, but we are still going to do Sanger.
Yeah. I'm not sure whether I should ask this being recorded, but what does Sue think of Nick Cross's paper?
I haven't actually asked her but
okay.
But
you ask Sue and then you text me or email me the comments. If she's sticking to Sanger, then we won't change.
I will come back to you. But but as I said, all those mutations I show you, they were just Sanger.
Yeah,
They were
I fully agree. Okay, so Carol, you have the answer. Maybe we should have a CML group. If Novartis will be with us for the next few years, we can have a CML group. Well, the Novartis big bosses are not here. You all have to carry back to the Novartis. Okay, I think we really exceeded time. David, it's really been nice catching up with all of you. I think hopefully you have to go to the John Goldman meeting soon and catch up with you. Thank you everybody for a very fruitful session. Thank you.
Oscar. Thanks.